This module will provide you with a review of content from your Foundations course, along with some specific details regarding hip exercise. I hope that this module, along with active participation in lab, will help you to justify selection and dosage of a mobility exercise based on a patient's functional limitations and exam findings. Select exercises based on muscle performance deficiencies. Appreciate importance of lumbar muscle performance to hip pathology. Adjust exercise based on health condition and patient performance, as well as to demonstrate effective cueing and facilitation strategies. We will start off with a familiar slide that provides a generic explanation of therapeutic exercise, which is planned performance of physical movements, postures, or activities with the goal of remediating or preventing impairments, improving activities and participation, preventing or reducing health risk factors, optimizing overall health and well-being, all of which should be individualized to your patients. We will look at another familiar figure with the hip now in mind. Regarding mobility, in this lab you will prescribe exercises either at the hip joint or hip musculature based on your exam findings. You should be familiar with how to prescribe flexibility exercises to the hip flexor group, hip rotators, hamstrings, adductors, as well as the TFL-IT band complex. When we observe and prescribe exercises addressing neuromotor control of the hip, we are most concerned with pelvic positioning, including excessive anterior or posterior tilting, as well as Trendelenburg. We are also concerned with femur positioning, including internal or external rotation, as well as ab or adduction. Regarding stability in the hip, we will focus on the lumbar stabilizers learned earlier in this course, as well as the gluteal's ability to provide stability to the pelvis and hip. Similar to neuromuscular control, for posture, we will focus on the lumbopelvic position and the hips position, whether they be in flexion, extension, or rotation. And finally, in the hip, we will focus on muscle performance of the gluteals, hip external rotators, and lumbar muscles. Based on patient presentation, we will want to select exercises that either promote activation, endurance, strength, or power. The ICF also guides our exercise selection. We may select exercises based on the health condition by choosing exercises that protect tissue by avoiding contraction, specific range of motion, or a specific direction of movement. For example, if a patient has a gluteus medius tendinitis, we may want to limit frontal plane movement. Similar to if a patient has hamstring tendinitis, we may want to limit sagittal plane movement, but can train movement in other planes or train other surrounding muscles. We also select exercises based on a patient's specific impairments. Mobility and muscle performance exercises must address the specific level of impairment. If appropriate, specific hip activities we may want to train include the ability to lift, negotiate stairs, gait, squatting, as well as sitting. Lab will provide concepts and some examples, however, will not be an exhaustive list of exercises. Please refer to these resources for future needs in patient care. Recall some common impairments managed with exercise. I wanted to provide more specific examples of how hip exercise can manage hip pain. Consider general overuse syndromes, including acute tendon pathologies. We may strengthen the muscles around the painful tissue to mitigate excessive forces and demands that the tendon is exposed to. We may also facilitate, activate, and strengthen muscles that create faulty movement patterns that cause pain. If a patient has piriformis syndrome due to excessive femoral internal rotation with function, we may strengthen hip external rotators, including gluteals, to decrease the strain on the piriformis. For more subacute and chronic tendinopathies, we may begin with isometric contractions and then progress to heavy slow resistance training to improve the resilience and pain in that tendon. Also, if we find a muscle shortened due to muscle spasm, we may activate the muscle on the opposite side of the joint, allowing for reciprocal inhibition. For example, if we find painful spasm in the TFL, we may activate the posterior fibers of the gluteus medius to allow for relaxation of that TFL. Reviewing this schematic, we see that muscle performance consists of strength, endurance, and power, and that strength is a function of neural adaptations and hypertrophy. We may see an improvement in performance quickly more due to neural adaptations than hypertrophy. We will use resistance exercise to elicit these improvements. Recall that resistance exercise is a dynamic or static contraction resisted by an external force, either manually or mechanically elicited. Once a patient achieves proper form and neuromuscular coordination demonstrated by activating the correct muscles during an exercise, we need to provide a high-intensity stimulus for 8 to 12 repetitions. That means the external load, whether manually or mechanically, needs to be enough so that the patient can complete 12 reps maximum, or their RPE is 8 out of 10. A very important point to make, however, is to proceed with caution if you are looking to EMG studies to select an exercise with a high percentage of maximum contraction. Most of these studies are done on healthy individuals, so may not generalize to our patients in pain or having other impairments. Also, during the protection phases, we may want to select exercises with lower demands on a muscle to allow for minimal muscle activation, but still protecting while healing. Remember, your patient is likely experiencing their health condition due to faulty movements. Thus, take care in pushing intensity too high initially, where the patient is at risk for compensating. So far, we have talked about how to account for health condition and impairments in exercise selection, and if you have determined resistance exercises needed, we need to make another decision. Static or isometric contractions may be selected if you have a goal of muscle activation, if you want to protect a particular range of motion, or during early management of tendon pathology. You may choose concentric or eccentric exercise based on what the patient is having difficulty with. Consider the role of the gluteus medius in gait or gluteus maximus in descending stairs. Eccentric demands in both of these scenarios need to be considered. You also need to consider open versus closed chain exercises. Open chain may allow for more muscle isolation if that is desired, while closed chain has the benefits of function, joint approximation, and stability. However, with multiple joint and muscles coordinating, there is a higher risk for compensation. You must also determine when manual versus mechanical or consistent versus variable resistance is most beneficial. In general, we can use this list to help guide progression of exercises. We may increase body weight, manipulate base of support or surface. We can also make the exercise more challenging by adding multiple planes and progressing the speed. Regarding dosing for general resistance exercise, please review the FIT principles you learned in Foundations. I also want to help you briefly review flexibility exercises. Remember that we can prescribe dynamic, static, or PNF flexibility exercises. You may also review the parameters you learned in your Foundations course, as these will be used in the lab's discussion regarding flexibility exercises. As we step away from mostly review into more specifics of the hip, I want to draw your attention to the importance of training the gluteals in patients with hip pathology. These muscles are important for load transfer, structural stability, and alignment of not only the hip but also the entire lower kinetic chain. Impairments in the performance of these muscles have been shown to be risk factors of low back pain, IT band syndrome, patellofemoral pain syndrome, chronic ankle instability, as well as various health conditions of the hip. Our attention may be drawn to training the gluteals even if you find a strong manual muscle test. However, note the following during a movement analysis. I would advise you first to observe movement, then provide a cue. If a patient is able to correct, exercises directed more at motor control can be prescribed. If the patient is unable to correct, we must first address strength and activation and then progress to using that new muscle strength in function. These following slides are not to be memorized, but to present you with a future reference. A more recent protocol for hamstring tendinopathy breaks rehab into 4 phases. In the early phase, use isometrics to reduce pain as well as address impairments of the lumbar and gluteal muscle performance. In the later stages, a 0 to 3 out of 10 pain is acceptable during and after exercise, but should settle within 24 hours. Stage 2 introduces hamstring exercises, but in a lesser degree of hip flexion, which is then progressed in Stage 3. Stage 4 is reserved for those returning to a higher level of recreation or sport. We will practice some of these exercises in lab. The literature is currently trending towards a general diagnosis of lateral hip pain versus separating out trochanteric bursitis and glute tendinopathy. In general, if the bursa is irritated, we want to avoid repetitive rotation as well as repetitive add and abduction at mid to end range adduction of the hip. However, the patient may be able to tolerate gentle isometric muscle activation and greater degrees of hip abduction and neutral rotation. Our main goal with this health condition is to correct joint mechanics and flexibility. For gluteal tendinopathy, we see the same parameters as hamstring tendinopathy. However, this time we are more concerned with the amount of hip ab or adduction versus hip flexion or extension. We want to avoid compressive and strong tensile loads that the tendon experiences. We begin with isometrics and progress towards heavy, slow resistance training. Exercises should start in a greater degree of hip abduction and then progress to neutral, finally allowing for slight adduction. And finally, a quick note on considerations when prescribing exercises for intra-articular hip pathology, whether it be osteoarthritis, FAI, or labral pathology. One of our goals is to correct joint mechanics of the lumbar spine and hip with special attention to anterior pelvic tilt and femoral internal rotation along with adduction. Also, consider the benefit of closed chain exercises for joint stability. However, you may begin in partial weight bearing, then progress to full weight bearing. We also want to be mindful of the range we are training in. It is advised to begin training in mid ranges, then progress towards end range as tolerated. It is also important to include sensory motor training in these individuals. You have been presented with a lot of information, both new and review. So how do you organize and remember all of it to design exercises for your patient? You may always use these following questions to guide you. Thank you for reviewing the module and preparing to actively participate in lab. I look forward to seeing you then.